Good morning. I'm Dr. Rutledge, and I'm going to be speaking to you this morning about the performance of the Mini-Gastric Bypass and tips and pointers from my experience. Let me first say that we're gratified that surgeons around the world have begun to adopt the Mini-Gastric Bypass. Myself and other surgeons who have performed the MGB, particularly those who've done more than 100 or more than 500 cases, are of the strong and uniform opinion that the Mini-Gastric Bypass is a truly superb form of weight loss surgery. And I think most of us, in fact all that I've spoken with, are of the strong belief that the Mini-Gastric Bypass is probably the best choice for weight loss surgery at the present time. Now, having said that, it doesn't mean that the Mini-Gastric Bypass is perfect. It doesn't mean that it has no complications. And to restate that without the double negatives, what we'd like to say is we think that the MGB is very good, but like all medical and surgical therapy, it comes with risk. It comes with dangers. And so we're excited that surgeons are adopting our new approach. We're pleased and supportive of that. On the other hand, our hard-won experience, having performed thousands of these type of surgeries, gives us the opportunity to potentially help others who are taking up the Mini-Gastric Bypass for the first time. So this tape today is about the Mini-Gastric Bypass itself, not the results and not the other pieces of the MGB, but the actual operative performance. And let me point out that in addition to having videos on YouTube, many of us surgeons who are skilled in the Mini-Gastric Bypass have been volunteering to help others learn how to do the surgery. Please remember, don't hesitate to email or call me if I can help at any time, both with the operative, preoperative, or postoperative management of Mini-Gastric Bypass patients. Because our overarching goal is to help others, to help patients and their families avoid the problems of obesity and the problems of obesity surgery complications. And to that end, we actually now have a IFSO, International Federation for Surgery of Obesity survey that is being sent out across the country and then around the world to try and determine what people feel about weight loss surgery these days and some of the tips and pointers we can garner from our colleagues. So with that said, I'll use my own experience as a guide for the rest of this presentation. We're going to talk about preoperative preparation. There's a really extensive list of issues. One of the things we say as a simple part of that guidance that we can provide here on the tape today is that as a new program in the first 1 to 50 cases, we strongly recommend that only the lowest risk cases be chosen. And so what we're thinking about there is we're talking about under 300 pounds, no associated medical illnesses, no previous abdominal surgery, really the simpler type of cases for the first 50 cases. There is, I think, a learning curve to using the Mini-Gastric Bypass. We want very much to have success and taking on a challenging, very large patient who potentially could have an enlarged liver, who might have adhesions from previous surgery, might have an associated attendant large diaphragmatic hernia. These kinds of problems are ones that the Mini-Gastric Bypass is eminently capable of dealing with, but our belief is that during the first 50 cases in particular, it's very important to choose just the best risk, lowest risk type of patient. We don't want to be faced with the most challenging problems in Mini-Gastric Bypass surgery early in your experience. And this is kind of obvious, but we have seen new MGB surgeons get so excited about it that they want to flip their entire practice immediately. Recently we had a presentation of a surgeon who'd done 1,000 Roux-en-Ys, and so he started doing MGBs, and he was comparing his MGBs to his 1,000 Roux-en-Ys, and he did both of these at the same time period. So the end of his series of Roux-en-Ys was at the same time as the beginning of his series of MGBs. Now the MGBs were better than his Roux-en-Y series, but he had more complications and problems than we would like to see. So our advice, again, restrict the patient choice in the early part of your new practice. Now when we start, we may start in the operating room, we could start the morning of surgery. There are a lot of details that we're not going to focus on this morning. But as the patient comes into the operating room, we want to make sure that before anything further is done, that the instruments are available, the staples are available, the sterility has been confirmed, the patient identification has been confirmed, the operation of the day and the patient are identified, and anesthesiologist prepared, the drugs are available for the anesthesia, and then the patient is placed on the operating room table. We place the patient in a flat table, not broken in any area. What we mean by broken is into like a head up or a position like that. So it's a flat table. It's just a straight table. The legs are not split. They're not put in stirrups. My practice is the straight supine flat table. We know that the French technique and others use the operation between the legs. We won't get into that controversy today, but I'm just presenting my approach today. Our next step, once the patient is on the table, is to discuss the anchoring of the patient. We put both arms out basically perpendicular to the table. Following that, we anchor the patient to the table by placing 2 pillows under the knees, padding the heels and any other points that are appropriate. Cover the patient's lower body, and then anchor the patient to the table with 3 large seatbelt type straps. These are straps that are 3 to 6 to 10 inches wide, and they're actually seatbelt materials, so they have a bursting strength of several thousand pounds. So we're not talking about a lightweight or a small type of strap. And we place 1 in the mid tibia and 2 on the mid thighs, 1 on the lower and 1 on the upper mid thigh. And they should be firm and tight but not constricting. These will be the main anchors for the patient while we tilt the patient during the surgery. So what we're going to expect during our operation is we're going to tilt the patient up and over towards the operating surgeon so that he doesn't have to lean over quite as much. We want the surgeon at ease with his arms and elbows roughly 90 degrees. And in this comfortable position with head straight up, we have the best opportunity to allow him to perform at his maximum. And so it's important at this point in the preparation of the patient that he or she be anchored to the table well, and we have found in 6,000 cases that using this approach is fine. There is questions or tips or pointers we might mention, and that is, in particular, some people want to put restrictions, bandages, things like that on the upper body, head, neck, or arms. And what we found is that's unnecessary and potentially constricting, may be obstructive to respirations, and so we don't recommend it. The head can be supported, usually with a donut, sometimes sandbags, or other similar things on either side of the head for the potential movement of the head during the turning of the table. Again, we're going to focus on the anesthesia. Just briefly to mention, we use a very specific type of anesthesia. The goal that we have during our anesthesia is to minimize the use of narcotics and inhalational anesthetics. And the reason for this is pretty clear. Both narcotics and unexpected recurrence of the inhalational anesthetics can cause respiratory depression. And in a morbidly obese patient who is undergoing abdominal surgery, there's a significant risk of respiratory compromise, especially as many of them come to us with respiratory compromise at the beginning. prior to their arrival. So there is a strong history of sleep apnea, obstructive pulmonary disease, asthma, and other problems. And so the weight, the abdominal surgery, and then the addition of narcotics and inhalational agents, we believe is not a good choice for these patients. And so my anesthetic technique for now over half of my 6,000 patient series is a TIVA, or total intravenous anesthesia, with propofol and a short-acting narcotic. And more recently, in the last 1,000 plus, what we have used is the combination of TIVA plus opioid-sparing anesthesia. And the idea behind this is that narcotics, or opioids, are really wonderful drugs. I mean, they take human beings out of pain. And this is a benefit to mankind that really can't be overstated. It's just all of the pain and suffering that has been alleviated by opioids or narcotics is just makes them truly miracle drugs. On the other hand, like we talked about with the mini-gastric bypass, opioids or narcotics come with attendant dangers. And just like the inhalational agents, these two attendant dangers are simple and straightforward, but also potentially deadly. And they are respiratory depression, that is, they can inhibit breathing. And second is nausea and vomiting. So if you've ever taken a codeine tablet and suddenly felt like throwing up, there's that effect on the emetic center at the base of the brain, so that it's important to recognize that using narcotics, although they're almost miraculous in their advantages, they also have significant risks. And those risks are things that we would like to avoid in our patients. So we choose to look at the latest research in the area of opioid-sparing anesthesia, and we add two drugs to our anesthetic management. And one is ketamine, an old drug that's been available for years, and the other is a new drug that's not available everywhere. It's called Precedex in the United States, or dexmedetomidine. And these drugs act on the N-methyl-D-aspartate receptor and the alpha-2 receptors in the brain, and they can give analgesia and anesthesia. Now, high-dose ketamine can be used for anesthesia on its own. What we do is use it in lower doses as a method of trying to get opioid sparing. What we mean by that is the ketamine has some analgesic effect, it has some anesthetic effect, and so by using ketamine, we can find that we can use significantly less narcotics. Now, when we get the same high-quality pain relief with lower amounts of narcotics, we get less respiratory depression and less risk to the patient. The other advantages of ketamine is it's a bronchodilator, and it tends to stimulate blood pressure. And when we use some of our medications, the propofol and narcotics can drop the blood pressure. So the combination we have found is a very good one, and we strongly recommend it. The Precedex, or dexmedetomidine, is a drug which has also got some real great benefits. It can actually be used as an anesthetic on its own. But again, what we found is it can be opioid sparing. We can use less of the propofol and remifentanil. And then because it has a little bit longer half-life, we can wake patients up. And the interesting thing, we can have patients who are somnolent or sleepy, but they have better maintained vital signs. That is, they tend to keep their respirations and their blood pressure, even though they may still be sleepy, and so it gives us a much better recovery. And what we do is we dose the ketamine on arrival, and we see what the patient's response is, and we increase that dose until we get signs and symptoms of somnolence. And then we give a loading dose of 100 milligrams of dexmedetomidine, start the propofol and the induction. So that's the anesthesia, and I see, given our time, that's about where we can finish for this tape. So we'll stop here with the plan that we'll have more on the performance of the mini-gastric bypass in our next episode. Thanks very much. This is Dr. Rutledge, and we'll see you again soon.